Hello everyone, a very good morning. Today let's discuss on a very important 5-mark question, that is our birth injuries. This is your important 5-mark question in your university exam, both for UG and also for PG. Okay, yes. Starting off with the introduction, I've taken every notes from our IJPP 2024 article only. Yes. Starting off with the introduction, birth injuries is an incidence varies depending upon the fetal presentation. So the incidence of your birth injuries, it varies depending on the fetal presentation. Yes. What are the risk factors for your birth injuries? So the risk factors for your birth injuries are being classified into 3. One is your maternal factors, second one is your fetal factors, and third one is any procedures that is causing a increased risk, that is leading to an increased risk for the birth injuries. Starting off with the maternal factors, first one is your primary mother or a primary gravida, second one short station, third one is your pelvic floor abnormality, fourth one when the mother is obese. So these are the risk factors, maternal risk factors for causing your birth injuries. Next, coming on to the fetal factors. First one is the extreme prematurity. Secondly, it is a macrosome baby. Third, when the child has itself a fetal anomalies. Fourth, when the child has different presentations such as breech presentation or bro or transverse lie. So these are the fetal factors that are being an increased risk for your birth injuries. And coming on to the procedures like instrumental delivery. Second one, when you do an external version. So when there is an external version, there is a prolonged labor. Fourth, when there is a precipitate labor. These are the procedural factors that is causing an increased risk for the birth injuries. Next, going on to the topic proper, that is our birth injuries. In birth injuries, we have our extracranial injuries and our intracranial injuries. So in extracranial injuries, we have caput. First one is a caput, second one is a cephalohematoma, third one is a subgaleal hemorrhage, fourth is your skull fracture. Going on to the intracranial injuries, one is your subdural hemorrhage, which is most common, and subarachnoid hemorrhage is the second most common, and third one is your epidural hemorrhage, and which is very rare, and fourth one is your cerebral and cerebellar hemorrhage, that is also very rare. Okay, so we'll talk about each of this topic. Okay, yes, and their management also. So first talking about our caput. So caput succedaneum, we have already discussed this in our previous video. That is, the cause for caput is your prolonged labor. When there is a prolonged labor, what will happen? The veins that is present in the scalp of the baby will have an increased hydrostatic pressure. So when there is an increased hydrostatic pressure in the veins, this will lead on to the seepage of your fluid into the interstitial space. So seepage of the fluid into the interstitial space, that is, in interstitial space you will have the fluid accumulation. The fluid is mainly a serosanguinous. The accumulation is in your subcutaneous plane. Since it is in the subcutaneous plane, it can cross the suture line. First point. Second is that it doesn't have a distinct margin. Do not have a distinct margins, and it is a soft swelling. The maximums will be present at the time of birth itself, and resolve. How it will resolve? Resolve on its own by 2 to 8 days. These are the main points that you have to know about your caput succedaneum. Yes, and there is no treatment is indicated for this. So no treatment is indicated. Yes. Next, going on to our second injury, that is our cephalohematoma. So cephalohematoma occurs because of your rupture of dipolic veins. When there is a, for example, when there is this thing, what is it called, forceps delivery. For example, a forceps delivery that is causing injury to the child, that can lead to the rupture of dipolic veins. When there is a rupture of this dipolic veins, it will lead on to accumulation of blood. As the name suggests, it is a hematoma, so there will be an accumulation of blood. So the accumulation of the blood will be present in your subperiosteal plane. Since it is in your subperiosteal layer or subperiosteal plane, it will not cause the suture line. It is a very distinct swelling. Maximum size will be present like 12 to 24 hours after the birth. Okay, and resolve. If suppose treatment depends upon whether it is a small cephalohematoma or large cephalohematoma, whether it is infected or not. So going on, supposing if it is a small cephalohematoma, it will resolve on its own. Okay, the resolution takes around, so resolution or result will take around by 2 to 8 weeks. Okay, next, occasionally this cephalohematoma can be calcified. So that cephalohematoma can become a calcification and cause a boggy swelling also, and this will present, and this calcification can be present for several months in the child. Supposing if it is a large cephalohematoma, okay, supposing if it is a large cephalohematoma, there will be an increased loss of blood, that is intravascular volume loss will be more. That way it will lead to anemia and hypotension in this child. So you have to compensate for this anemia and also for the hypotension also. Plus there will be an increased risk of hyperbilirubinemia or neonatal jaundice. This cephalohematoma, mostly it is associated with some linear skull fractures also, fine. And secondly, you do not aspirate. So do not aspirate the hematoma. Do not aspirate the hematoma only when it becomes infected. Unless it is infected, you do not aspirate. Only when it is infected, you do aspiration. Fine. Next, third point is, if there is a depressed skull fracture, if there is a depressed skull fracture, or if the child has neurological symptoms, then you take on a seal brain. Okay, this is the management for your cephalohematoma. Yes. Next, going on to our third birth injury, that is your subgaleal hemorrhage. So this subgaleal hemorrhage is a very life-threatening one, and the mortality of this subgaleal hemorrhage will be around 14%. It's a life-threatening hemorrhage, and its mortality is very high, around 40%. Why? Because this aponeurotic layer in which the blood gets accumulated, it is a very large area that is starting off with the orbital bridge, starting off with the orbital ridge in the front, going back to the earlobes, behind the earlobes at the side, and thirdly, in the back there will be an occipital ridge. So the very large area, so this very large area can accumulate around more than or equal to 40 ml of blood can be accumulated in this large area. Since there is more than 40 ml of blood can be accumulated in this large area, the child will go on for shock, hemorrhagic shock, right? Yes. When you find a child with some hemorrhage swelling in the head with the features of this diet, that is, when the child is having tachycardia, falling hematocrit, and increase in the head circumference. This should alert you to the subgaleal hemorrhage, and you require an immediate treatment for this, right? You have to monitor the head circumference regularly. Even if there is a 1 centimeter increase in the head circumference, there will be a nearly 40 ml of blood can be accumulated. Understood? It is not 40, sorry, this is not 40 ml here. More than or equal to, not 40 ml, it is more than or equal to 40% of the blood volume of the child can be sequestrated in this large area that is leading on to this, what is called your hemorrhagic shock. So what is the management of this child? Management is, you have to admit this child in ICU. Regular monitoring of vitals is required. Next is fluid resuscitation. Fluid resuscitation with PRBC is required, because you have to replace the blood, right, along with supportive care. Next, once the child is stabilized, then you go on with the CT brain after stabilization to rule out your skull fracture and your intracranial hemorrhage. Yes. Going off with the fourth injury, that is your skull fracture. So in skull fracture we have two types. One is your linear fractures, another one will be your depressed skull fracture. Okay. So this linear fracture, it mainly involves your parietal bone. So this linear fracture, it mainly involves the parietal bone, and it is associated with a tear in the dura layer and associated with tear in your dura layer or dura membrane. Okay, so this can lead to the development of what is called as leptomeningeal cyst. Next, in a depressed skull fracture, this depressed skull fracture are also mostly, these are associated with intracranial hemorrhages. Okay, so what is the management of the child with the skull fracture? So the management is fractures without a neurological deficit. So when the child is having a fracture but no neurological deficit, that is without neurological deficit, you do a conservative management. Okay, next, supposing if the child is having a depressed fracture, the depression is more than 2 centimeter. When the child is having a depressed fracture in which the depression is more than 2 centimeter, along with there is a presence of bone fragment. There is a presence of bone fragment in your brain, or the child is having a neurological deficit. Okay, the child is having neurological deficit also, these require a neurosurgical intervention. So when there is a depressed fracture, which is the depression is more than 2 centimeter, along with the fragment, bony fragment that is present in the brain, or if the child is having a neurological deficit, then you go on with the neurosurgical intervention. Okay, so these are the main points regarding your extracranial injuries. Next, you have your intracranial injuries. So intracranial hemorrhages or intracranial injuries. So what are the other topics you have is intracranial injuries. Next, you have brachial plexus injury. These are the main topics we need to cover in your birth injury. Okay, I'll take these two in our next video session. Okay, thank you. Have a nice day.